conflict of interest because we've been working with GE to develop free online training modules using POCUS as part of my role as a vice president of the Royal College of Obstetricians and Gynecologists. Well, first of all, what's the definition of POCUS? Well, POCUS is the imaging and the clinical interpretation of ultrasound performed at the patient's bedside by a clinician. So what's the difference between POCUS and the handheld ultrasound? Is it synonymous? Well, POCUS, strictly speaking, doesn't really mean handheld, but because it's the portability, the internal power, the rapid startup, handheld devices are actually becoming almost synonymous with the POCUS. That's not necessarily sort of the definition or the emphasis that was demonstrated in this document by the Australian Society of Ultrasound Medicine, where actually really they highlighted that the POCUS is difficult to define. The fact that there's confusing definition is the bedside, is a point of care. And really they focus more, or the proposal it should be substituted, is it ultrasound is focus, limited, or comprehensive? This document was published in 2017, and certainly if you read this document, you would see that probably things have moved on, and perhaps maybe in the next version of this document, they will incorporate new developments and new changes. I think it's important to highlight that there are potential several uses that we can use the point-of-care ultrasound or the handheld ultrasound for. So starting from confirming the fetal viability, so checking the fetal heart, but also checking the number of fetuses, is it single, twins, or higher, assessing the amniotic fluid volume, diagnosing polyhydramnios or oligohydramnios, determining the fetal position, except anterior, except posterior, and that could be very beneficial prior to instrumental delivery or for intrapartum ultrasound, also confirming the fetal presentation, and that could be both antenatally or intrapartum, so breech or cephalic, for example. Determine the placental location, so is it high placenta, is it placenta previa, but also pregnancy dating, where now there is the ability that you do measurements or assessing the biometry, and also detecting some fetal abnormalities. Not just that, but we started also using the handheld or the ultrasound for additional things. So for example, in our fetal intervention training course, we did use the Vscan Air or the point-of-care ultrasound for actually doing ultrasound-guided procedures. I'm going to focus the next few minutes on the fetal presentation. About 3 to 4% of the fetuses are in breech presentation at term, so about 36 weeks or beyond. I work in the UK, and the UK, if you are low-risk pregnancy, you only have 2 routine ultrasound scans, the one in the first trimester, 11-13 weeks, and the one at about 20 weeks, a normally scan. And in some very few hospitals, they also do routine third trimester ultrasound scan at 36 to 37 weeks. And where I work at St. George's Hospital, we have introduced that just before the COVID-19 pandemic. When it comes to fetal presentation, the conventional approach, at least in the UK, is the midwife or the obstetrician will palpate the maternal or the pregnant woman abdomen and detect or try to predict the fetal presentation. And we know that this approach is only about 60–70% accurate for breech presentation. So that means we miss about a third or 40% of them. And the problem with undiagnosed breech presentation, labor that's associated with increased perinatal mortality and morbidity, and also have medical legal implications. So this case was in the news with a case that was undiagnosed breech in labor, and unfortunately the baby had cerebral palsy, and it settled for £37 million. And therefore, the problem that we have is that about 1/3 to about 1/2 of the breech babies are presenting in labor, only in labor. And that means they end up by emergency C-section, or they have unexpected vaginal breech delivery. Both of them are associated with maternal and infant risk. So when last year we published this paper in PLOS Medicine, where we looked at the impact of doing this point-of-care ultrasound versus a routine third trimester ultrasound scan on the instance of undiagnosed breech presentation, but not just that, but also on perinatal outcomes. And what we found is that when we introduced or we did the routine certain ultrasound that's done in a hospital by the qualified sonographer, you reduce the incidence of undiagnosed breech in labor at term from 14% before to about 3%. So a significant reduction. But what was even more interesting is that we can achieve exactly the same by doing a point of care ultrasound, and that was in a hospital in the UK, in Norfolk and Norwich. And this was done by the midwives in the community during their routine visits. You see here incidence of term breech diagnosis from 16% to about 3.5%. So 70% reduction in incidence of undiagnosed breech, and not just undiagnosed breech in labor, but also reduction in the incidence of low Apgar scores, 80% reduction, and nearly 80% reduction in perinatal mortality, nearly 70% reduction in hypoxic ischemic encephalopathy. So important clinical outcomes. And another study that was from Cambridge, led by Gordon Smith, where they did a universal late pregnancy ultrasound in primary gravid or primiparous women. And they reported that by doing this, you almost eliminate undiagnosed breech presentation in labor, you reduce the perinatal mortality and morbidity, and it estimated that you save at least 7 babies' lives a year in the UK. And also importantly, that you give the woman the opportunity of informed maternal choice of mode of delivery. So when you diagnose that you have breech at 36, 37 weeks, that means the woman can opt or choose to have elective C-section, can have an ECV, or actually can opt for vaginal breech delivery. What about the cost? Is it cost effective to introduce the routine third-trimester ultrasound scan? Well, the health economics or the calculation in the study, with the fact in order for it to be cost effective, the routine ultrasound needs to be the cost list need to be less than £20. And at the moment, the national tariff in the UK to do a routine third-trimester ultrasound by a sonographer in the hospital as a separate visit is about £50. So it's unlikely to be cost effective. But if we are able to perform this ultrasound specifically focused for fetal presentation by the healthcare professionals or the midwives or doctors in routine during the routine antenatal visit using handheld device, this is likely to meet this threshold of £20. So, and therefore there is evidence now that if you train healthcare professionals to perform presentation scan at term, or in the third trimester, that you actually could potentially improve the quality of the service. You reduce the incidence of undiagnosed breech in labor, you reduce emergency C-section, you reduce the perinatal mortality and morbidity, but also there are important logistic issues in terms of service provision. You increase the speed of access ultrasound, you reduce the waiting times and anxiety of the parents, and also you reduce sonographers' workload. Certainly in the UK, we do have shortage of sonographers. Is there evidence to support this length of stay, or you can have provide a rapid or easier rapid access to ultrasound? And this study, where they looked at the effect of the emergency physician performed point of care ultrasound versus the radiology department performed ultrasound on the length of stay in among pregnant women in the first half of the pregnancy. And they reported that by doing this POCUS, an emergency department by the physician, you reduce the length of stay by 31 minutes. And when they exclude the cases that the POCUS was inconclusive, and therefore the patient had to be referred to have a radiology ultrasound, you find that you reduce the length of stay by 75 minutes. How about the views of healthcare professionals? If you want to implement something new, you need to engage with the healthcare professionals. And this study we did last year, where we actually asked the midwives in the UK, and they almost 90% were quite supportive. They felt that the training would improve their skill set in determining the fetal presentation, but of course raised the, there are some challenges that we have to overcome in terms of the training, ensuring competency, and also provision of these devices. Another important point that when you implement a new change, for example, the POCUS, it needs to be integrated within the care pathway. It can't just stand alone. So, for example, here, scanning for fetal presentation in turn, you need to include a section about what about if the healthcare professional is unsure when they're doing the scan, and they might actually have to refer for the routine ultrasound scan. So ensuring that there's all the governance aspects are met. Obstetric emergency is one of the key really advantage of the use of handheld ultrasound is the speed of its access. So we did this experiment where in fetal bradycardia, you need an emergency cesarean section. If you conventionally, you will have this high-end ultrasound, you bring it to the theater, you plug it in, and it took about 2 minutes, 20 seconds until we actually can do an ultrasound scan in an emergency situation, while when we do that using the handheld or the POCUS, it took about 30 seconds, so it saves time. How they compare with the high-end ultrasound system, and the systematic reviews did actually conclude that they were comparable, but actually we really need to have this mentality that the POCUS or the handheld ultrasound, they're a supplement to our examination, complementary, and allows easy access to diagnostic tools in pregnancy. So is there evidence that it does reduce maternal and neonatal deaths? And this study, which took place in the Philippines, they did an intervention, which is essentially training the community healthcare workers on the handheld ultrasound to identify mainly 5 obstetric conditions. They look at the fetal viability, the fetal number, singleton or multiples, placenta localization, amniotic fluid volume, and fetal presentation. And they did that, included women between 20 and 24 weeks from 2 regions in the Philippines. And they were scanned using the handheld ultrasound, but also with the GE, the high-end ultrasound, and that was for validation of the POCUS or the handheld ultrasound. And the outcome of the study was maternal and neonatal deaths averted. And that was estimation, not actual deaths, and was estimating if we would identify this ultrasound abnormalities. And we know from the data that this is potentially could save or avert an X number of maternal and neonatal deaths. In this study, they, and of course that's, that's not level 1 evidence, and therefore we need better quality evidence, but it's important to see various aspects of what could be achieved in the low and middle income countries. So in this study, they had 460 women scanned. About 1/3 of them had abnormal ultrasound with their placenta, like placenta previa, for example, fetal malpresentation, twins, and amniotic fluid volume abnormalities. And they estimate that they could possibly avert 6% of maternal deaths and 15% of neonatal deaths. Importantly, in this study I mentioned, they compared the hand ultrasound with the main end, and there was 99% agreement. So that's validation. And also in terms of the training, they trained the healthcare workers, and there was 95% agreement between ultrasound readings of the trainee and the trainers. So it's possible and feasible to train their healthcare workers in the community. So really, I think what we should think of the POCUS or the hand ultrasound as the obstetrician stethoscope. But very important that we ensure that these devices, which are easy to access, they are affordable or cheaper, and increasingly common, and provide high quality ultrasound, that actually the staff or the healthcare professionals are adequately trained and competent. And as I mentioned earlier, as my role in the Vice President of the Royal College of Obstetricians and Gynecologists in the UK, would develop an online training that's being launched next months, and that's using the handheld device or the POCUS. And this is the website, and will be free to access to all healthcare professionals, including doctors and midwives. And this is sort of some of the content. It will be interactive, and it has animations and videos. The practical tips, I think, just to really highlight that this is, if you see on the left-hand side, this is an ultrasound image that's obtained with a high-end ultrasound, compared to on the right, this is the ultrasound images you obtained using the handheld ultrasound. And you see that they're not exactly the same, and therefore you really need to be familiar, and when you train on using handheld ultrasound. And as I mentioned, some of the videos that we did during the training. And finally, just about the governance, because certainly some of the concern that was highlighted in the Australian Society of Ultrasound document is about actually that the images are not stored, and therefore it does not really fulfill doesn't fulfill some of the governance aspect. And there are some developments and using digital technology, so having the cloud where you can actually store these ultrasound images and being accessed and shared and potentially stored. but also having this remote share where you can get maybe second opinion from maybe a more qualified healthcare professional if you're not sure. So my take-home message is that a handheld ultrasound of the POCUS in obstetrics can help us provide safer maternity care. It can actually provide almost all aspects of the basic obstetric ultrasound. I think it has potential huge value, particularly in low and middle income countries and community practice, where you can have easier and better access to ultrasound, and potentially have huge value also in obstetric emergencies. But very important that we ensure that the healthcare professionals are trained and competent in performing the ultrasound scan using the handheld devices. Just leave you with this quote: POCUS is a limited focus exam that aims to answer a specific question, and it should not be viewed as an alternative to the formal ultrasound. Thank you very much for your attention. I'm happy to take any questions.